Good morning. I'd like to thank each and every one of you for being here with us like live session from MAHSA University Southern Africa campus. I'm Damayanti, lecturer from Faculty of Health Sciences, MAHSA University, and I'll be moderating today's session. Today's webinar, titled Scapula Motor Training, uh, is proudly organized by the Faculty of Health Sciences, Nursing and Education, MAHSA University. Dear viewers, before we proceed further, I'd like to give you a brief overview of the programs offered by Faculty of Health Sciences at MAHSA University. Faculty of Health Sciences, Nursing and Education comprise of School of Education, School of Physiotherapy, Department of Environmental Health, Department of Medical Imaging, and School of Nursing. Okay, under School of Physiotherapy, we have Diploma in Physiotherapy, Bachelor of Physiotherapy, full-time, Bachelor of Physiotherapy, ODL mode, and Master of Physiotherapy. Under Department of Environmental Health, we have Diploma in Environmental Health, Bachelors of Environmental Health and Safety, full-time program, Bachelors of Environmental Health and Safety, ODL, and we have a diploma in occupational safety and health. So next, under the Department of Medical Imaging, we have a diploma in medical imaging radiography, Bachelors of Medical Imaging full-time program, Bachelor of Medical Imaging under ODM. Okay, why join health science course? It's high job demand, where it's group under essential services and no boring work routine. Can earn lucrative remuneration, and a career you can feel good about, and you have the opportunity to work in a variety of settings and low risk of job redundancy, and because it can't be automated. So in MAHSA University, we have Master of Physiotherapy. It's a full-time program for 1 year and a 2-year program for part-time. So this is the entry requirements. So we do have a Bachelor of Physiotherapy full-time program and Bachelor of Physiotherapy open distance learning ODL, Bachelor of Environmental Health and Safety for the full-time, Bachelor of Environmental Health and Safety for the ODL, Bachelors of Medical Imaging full-time as well as the ODL for this Bachelors of Medical Imaging. So this is the entry requirements. And we do offer a diploma in physiotherapy, diploma in environmental health and medical imaging. So this is the entry requirements for the course. And diploma in occupational safety and health is a 3-year program. This is the entry requirement. So I choose Faculty of Health Science MAHSA. It's an experienced and dedicated international pool of academic staff. It has various studies modes such as conventional, open and distance learning, cross-teaching by faculty, and accredited by the MQA and JPA with international recognitions. And we do have a wide list of hospital and institutions for clinical and industrial placement. And there's an interactive teaching and emphasis on hands-on skills, clinical skills, and it can be a face-to-face and online platform. So we do have a MAHSA scholarship under Haji Abdullah Academic Excellence and Scholarship, Foundation Scholarship, Blue Ribbon Scholarship, School Teacher Scholarship, Family Scholarship, the Single Parent Scholarship. And we have a collaboration affiliation with World Confederation for Physical Therapy, Malaysian Physiotherapy Association, Anglia State University, and many more. And we do have a student mobility program carried at the University. Lovely Professional University, India, and University of Sriwijaya. So we welcome you to join us at MAHSA University. Thank you. Okay. So please contact us through MAHSA website or through our faculty Facebook to know about more of these programs, and or simply leave a comment. Okay. So today I'm going to introduce about today's webinar. It's titled Scapular Motor Training, Motor Control Training. So this webinar will provide an overview of scapular motor control, emphasizing its critical role in ensuring upper extremity stability and coordination. So now let me introduce the speaker of today's webinar, Ms. Noor Aina. Ms. Noor Aina holds a Bachelor's of Physiotherapy and Master of Physiotherapy in Musculoskeletal. She is currently a lecturer at Faculty of Health Sciences, University Technology Mara, Pulau Pinang, campus Vietnam. So Ms. Noor Aina, the screen is all yours.
All right, hello. Good morning to all of you. Before we begin the the slides, the presentation, I would like to introduce myself. Thank you, Ms. Tameti, for introducing myself. My name is Noraina. I'm currently teaching at UITM, and I have 7 years of clinical experience before pursuing an education program. All right. Um, Now we proceed with the sharing session. Today's topic is scapula motor control. All right. Why I would like to emphasize on scapula motor control because musculoskeletal, we have a lot of problem in musculoskeletal, especially in youngsters and adults, in elderly. So all of us, most of the people have the upper extremity problem, which next to the spine problem that's beside of it. But in the assessment of the musculoskeletal for upper extremity, sometimes we miss out the scapula motor control. We do the assessment for MMT, range of motion. We look for the scapula. We miss out. We check for the ROM. We check for MMT. That's for upper extremity. But however, sometimes we miss out the scapula assessment. So this is what we are going to look today, right? Okay. The next reason why I emphasize on scapula is because the scapula is the main muscle stabilizer, but the glenohumeral is more on primary mover. So that's why scapula is something that we have to emphasize on it because that is the base. So once the base is stabilized, then we can focus on glenohumeral. All right. Uh, Okay, moving on. So what we are going through for today's session is first I'm going to share the definition of motor control. Next, moving on to the scapular position at rest and scapular position during motion. I introduce about the scapular dyskinesia, motor control assessment, motor control treatment, and a few case study that we're going to discuss a little bit. All right. So what is scapular motor control? It is an exercise to correct alignment and coordination, which involve first, learning optimal scapular orientation at rest. Second, controlling optimal orientation during active movement. And in this exercise also, we can emphasize manual therapy technique, which commonly used to practice to manage the symptoms, which we use to lengthen the tight muscle or to reduce the active trigger point presentation. All right. Okay, I'm sorry, but can I hear any? Is it? Can you hear clear me well? Need to share the screen. Yeah? I didn't share the screen yet. Yeah. Okay. Sorry. Wait. Huh? Slide is not showing. All right. Oh, I forgot to share this slide. Sorry. Okay. Sorry. Can you hear? Can you see now? Okay. All right. Okay. Sorry. Okay, I forgot to share the slides. Okay, coming on to the first. So this is what we're going to go through, which is scapula motor control. Okay, I'm sorry. So the scapula, as I said before, scapula is the base of the upper extremity. So we need to stabilize the scapula before we go into the glenohumeral assessment. Okay, why? Because scapula is the base, the basic stabilizer, and the GH is the prime mover. So if we do not stabilize the prime stabilizer, so that's the reason why after we go for the treatment of for shoulder, the pain will come again and again because we do not stabilize. We do not get the stability for the scapula first. We just proceed to the shoulder. So that's why we are going to look for motor control of the scapula. All right, so this is the lesson objective. I repeat it. First, we're going to share the definition of motor control, the scapula position at rest, the scapula position during motion, scapular dyskinesia, motor control assessment, motor control treatment, and we're going to the case study. All right, so what is the scapula motor control? It is an exercise to correct the alignment and coordination. Okay, to correct the alignment and coordination, which involve learning optimal scapular orientation at rest and controlling optimal orientation during active movement. Okay, usually during any shoulder extremity condition, like for example, scapular impingement syndrome. Okay, even for shoulder impingement syndrome, you can see the scapula is in faulty position. It is not in the right position. So our treatment is focusing on learning the scapular orientation. We're going to put back from the faulty position to the right normal position that how we should have. Okay, once we get the right position during rest, then we can proceed to control optimal orientation during active movement. And also in this regime of exercise, we can add on the manual therapy technique. Why? Because we want to manage the symptoms, because some muscle, okay, as we all know that scapula is controlled by the muscles only. So there are some muscles are overactive and some muscles are underactive. So we can apply manual therapy to lengthen the overactive muscle, which is the that lengthen the tight muscle, and we can reduce the active trigger point presentations. So by having all of this regime, then we can get the right scapular orientation during rest. Then we can proceed to the active movement. After we get the scapular motor control in the correct order, then we can now proceed with the upper extremity shoulder exercises. Like for example, if you want to use the dumbbell, or we want to use or any closed exercise chain, or open kinetic chain, right? Okay, before we're going to access the scapula, we need to know what is the normal scapular position. Okay, if you can see, at rest, the acromion should be higher than superior border of scapula. The spine of scapula should be 15 to 25 degree rotated in coronal plane. Medial and inferior border should be tight against the rib cage, and the clavicle should have a slight posterior rotation in frontal plane. All right. From this, first we check for the first point. Acromion should be higher than superior body of scapula. That is the normal scapula position, okay, which is like I am giving an example. So this is the acromion and this is the body of scapula. Or you can see from the sides here as well. So here is the acromion. Okay, this is acromion and this is the body of scapula. So acromion should be higher than the superior border of the scapula. But however, there are certain condition, this is what we call faulty position. Okay, there are certain position where the scapula is tilted laterally. Okay, they're tilted laterally. They're tilted laterally where the acromion is going down and the superior body is going up. So the position is in this position. So this is in faulty position. It's supposed to be in this way, which is acromion is higher, but the certain position is going to be this way. So this is the faulty position. Okay, the question is how we're going to get the position in a right order. So how we're going to move from here to here. So this is what about the motor control is all about. All right, that's the first point. Second point, the spine of scapula should be 15 to 25 degree rotated in coronal plane. All right, so if you can see from the slides here, so usually the scapula is tightly against the rib. So they have about slightly degree of, it's not straight away like this now because we have the rib cage, right? So it's not going to be in this way. So it's slightly oriented this way. Okay, this is a good scapula at a normal human being. But however, there are certain conditions where the scapula, the degree of the spine is going like this, which is anterior tilted position. Okay, this is what we call the position of fault as well, anterior tilted position. Okay, so we have to check back which muscle are pulling the structure. Okay, if you can see the superior border of the scapula is going inferior and interiorly, and the inferior border is going posteriorly and superiorly. So this is where the faulty position. So we are going to check back which muscle is overactive and which muscle is underactive because we want to get back the position into this 15-degree position. All right? Okay. And there are certain conditions what we call a posterior tilted position where the scapula is going back like this. So by means, the superior border is actually going posterior and inferiorly, while the inferior border is going upwards, which is going superior and anteriorly. So this is also posterior tilt, also a position of fault. So we have to check back which muscle is lengthened. Okay, which is when the muscle is lengthened, the muscle is underactive. When the muscle is tightened, that is overactive. So we want to relax the overactive muscle and we want to work on the overactive muscle. We want to work for the underactive muscle. All right. Okay. For like this, for example, the patient is in posterior tilted. So we can see this is the spine here. Okay. This is the rib cage. So they have lengthened over these muscles. Okay. We should find the muscle to work for this one. So it means like we have to working on this upper muscle and also to relax on the lower down muscles, which is trapezius, lower trapezius, and we have to work more on upper trapezius in posterior tilted position. So that's why we have to understand the normal scapular position. Then we can check. So what is the faulty position, so that we can go back. We can go back to the rest to the normal position. All right. Okay, the last point is the medial and inferior border should be tight against the rib. That's a normal position of the scapula. It must be against the rib cage. But however, there are certain conditions where the cervix anterior muscle is weakened. So this is where the problems come in. So it can be anterior tilted, it can be lateral, medially tilted. So that's why we need to check which muscle is overactive and which muscle is underactive. All right, so this is the position at rest. Next, we're moving on the scapular position during motion. All right. As we all know, we already studied that scapula, they have 6 motion. Okay. They have 6 motion, which are elevation. Okay. The scapula is going up. Depression, the scapula is going down. Okay. Protraction, the scapula is going outward, which is abduction. Okay. Adduction, the scapula is going in, adduction, and also they have upward rotation and downward rotation. That is the normal scapular movement. And we know that the scapula move on the rib cage, and the scapula, it doesn't move on its own. Okay, they work together with humerus. That's what we call scapulohumeral rhythm. Okay, that's the motion, and this scapulohumeral rhythm are moved in 1:2 ratio. Okay, the movement must work in that order so that they have the rhythmic of the scapulohumeral. If there are weakening of one of this muscle, so the ratio has been have problem in the ratio. So that's why we can see there are certain condition they have the delay in the muscle. They have delay in the muscle activation, or they are too fast of the muscle contraction. So that is what we're going to check. All right. So next, 1:2 ratio. I again emphasize 1:2 ratio. So what does that mean by 1:2 ratio? So like for example, when the arm is abduction to 190, which is full range of motion, okay, the movement is controlled by scapula and humerus, and they have 60-degree rotation by the scapula and 120 rotation by the humerus. By means, when the scapula is moving 60 degree, the humerus is already in 60 degree, but the scapula is add on more 120 degree to get the full range of motion. But however, if the scapula cannot go to 60 degree, so what happened to the range of motion? So of course it's going down. They have the reduce in range of motion. So this is what we are going to check back. Okay, why certain condition after we give the exercise it doesn't get better because we do not check the scapular movement. Because the scapula are working together with humerus. When we already check we do exercise for the humerus, but it doesn't get better. Okay, we keep doing it, but the treatment, the outcome, the presentation is the same. So that's why we have to check for the pair of the humerus, which is scapula. All right. As I mentioned before, the scapula, they have movement, which is abduction, adduction, and the degree is only 25 degree. It cannot give more than that. If it is more than that, by means that they have the faulty in muscle. They have been underactive muscle that causing more abduction happen. Okay, but however, if they have limited, they have tightened muscle, for example, they have tightened of the rhomboid muscle. So the scapula cannot go to 25 degree abduction. Okay. Similarly, for upward rotation and downward rotation, the range of motion can go up to 60 only. If it go more than 60 degree, by means they are muscle underactive muscle. Yes, right. This anterior is weakened, so that's why it cannot control the motion. Okay. Similarly, if the rotation is reduced, so by means they have the tighten of the muscles as well. All right. For the elevation and depression, similarly, it must go to 55 degree only. It can go more, it can go less. It's around of that angle degree only. So if it's more, the range of motion is more than 50 degree. Okay. So by means I have a tighten of levator scapula, it's going up too much. So there are tighten of levator scapula and tighten of upper trapezius muscle. Okay. So the question is, so the upper muscle, the upper trapezius and also levator scapula is tightened. But however, the latissimus dorsi is going down, the downward side. Okay. The the latissimus dorsi and also the lower trapezius is weakened. So that's why they cannot control the elevation motion. Similarly, going down to depression, it must be going to 50 degree only. Sorry. And we have to remember that scapular motion is supported dynamically by its muscle. Okay, they have no other joint that control the motion. It's supported dynamically by muscle. So by means, if they have any problem with the muscles, so they will have problem with the scapula, either its position at rest or its going motion. So they have problem with that. So we always have to check which muscle is underactive, which muscle is overactive muscles. Okay. You can see from this video. Okay, again. They have the range of motion of the scapula. They're not going upwards too much. It's just going up nicely, just 1 to 2 ratio. At the first 30 degree, there's no motion by the scapula. The first 30 degree, there's no motion, just by the humeral motion only. Next, after 60 degree, you can see here, then there are motion by the, it will add on with the motion of scapula. So at 90 degree of humerus, the scapula will moving on to the 30 degree of scapula. Okay. One more time. Okay, see? So at here, this is 90 degree of range of motion, but only 60 degrees by the humeral and 30 degrees by scapula. So this is 1 to 2 ratio motion. Okay. So at full range of motion, you can see this is 100. This is 110, they have 40 degree, and if they have 180 range of motion, so there are 60 degree of abduction and upward rotation of the scapula. So I hope you can understand the 1:2 ratio and why it's important for the scapula to nicely move along the GH joint, along the scapulothoracic joint, so along the rib cage. If they have limitation of the scapular motion, so of course the humeral cannot get full range of motion. If there's too much of the, if the muscle is tightened, so the range of motion will be limited. But if they are full range of motion, but they have weakness over here, so that's what we call the scapular dyskinesia, which we're going to look after this. Okay. This is what we call scapular dyskinesia. Scapular dyskinesia is alteration or deviation in normal resting or active position of the scapula during shoulder movement. So just now we have learned about the normal scapular position. So if the scapula is not in the right position, either it's in resting or in active position, so this is what we call scapular dyskinesia. Okay, so this has happened due to intrinsic muscle pathology or inflexibility, inhibition of the normal muscle activation. So by means there are certain muscles are inflexible, they are tightened muscle, or inhibition of normal muscle activation. So by means the muscle is underactive. Okay, like for example, if the muscle if we want to do shoulder abduction, so they must have contraction of the levator scapula to make sure the scapula can go upwards. But if they are under activation, they have under activation of the levator scapula, so the scapula cannot go up, right? So that's why the range of motion will be reduced. That's what we call under activation or inhibition of normal muscle activation. And this will create possible impairment of overall shoulder function. Okay, shoulder function can be because of this happen because shoulder impingement. It can lead to shoulder impingement muscle. Most of it, or certain condition like for example, the shoulder problem that lead to scapular problem. So it can be vice versa. It's either the scapula is the main culprit or the shoulder problem that lead to scapular problem. But nevertheless, both condition we need to consider scapula in the treatment. All right. So if you can see from the picture, so we can see the deviation of the scapula. The patient is having a shoulder impingement syndrome, but he also have the scoliosis, thoracic scoliosis at the same time. So you can see the scapula, the inferior border is protruded. Okay, so from this we can see this is the protruded, and you can see here is the superior border here. This is the superior border is similarly with the acromion. So this is the faulty position. We know that acromion should be higher than superior border of the scapula, but however here you can see this superior border is in line with the acromion, so we know this is wrong already. And also if you can see the scapula is in internal rotation. It is already internally rotated, so that's why they have the protruded of the inferior border, and also they have anterior tilted of the scapula. Okay, so you can see this is the protruded and it's going down. We cannot see we cannot see the spine of scapula compared to this side. We can see the spine of scapula, usually we can see, but however, if the patient is anterior tilted position, we can't see the spine of scapula. But I can see this is a medial border only, but we cannot see the spine of scapula. So this, we get to know that the patient is having medial tilted, downward tilted, laterally rotated, and also anterior tilted position of the scapula. So what we going to do? That's the question. So next picture. Okay, this patient is having neck pain. They have not. It is not a shoulder pain, but the patient is having neck pain and upper back pain. So also we need to emphasize over the scapular region. Why? Because these are all related. The thoracic is very closely related to the scapula. So that's why the scapula can be the main culprit for the neck pain and also upper back pain. So if you can see similarly. So this is also anterior tilted position. But however, you can see this is the medial border. This is the medial border. The medial border is in a good position. This is superior border. This is superior border, this is an acromion. So also, it's an interior tilted position. So this is, it is in anterior tilted, but they are not in rotated position. For just now, this is in rotated position. This is not a rotated position, but all just anterior tilted position only. That's the difference. Okay. So this is the condition of shoulder impingement syndrome. So at rest, you can see that at rest also in faulty position. So what happened in inactive motion? Of course, the condition will get worse. You can see the scapula should abduction to 60 degree, but it's more than 60 degree. You can see here. Okay, it's supposed to be just this way, but you get more. Okay. So now the question is we need to know. So which muscle is underactive, which muscle is overactive, so that we know what we are going to do. So now here, so you can see the muscle up here is overactivated. That's why they have no control. This the upper here is overactivated and the down here is underactivated. Okay, it should be balanced between up here and down here so that the scapula can move 1:2 ratio to humeral rhythm. But if they are imbalance between up and down, so that's why the scapula cannot control nicely. So here we can see the upper part is overactivated. So which muscle can be a problem here? Okay, it can be because of activated of activated of upper trapezius muscle. Usually this one is upper trapezius muscle, but the weakness of levator scapula here. Levator scapula, when going down, it should be going up as well, but here you can see the scapula is going down, but here the scapula is going down too much downward. So levator scapula is weakened over here, but overactive over upper trapezius here. But here you can see it's the height of the scapula should be similarly. But if in laterally rotated, you can see they have too much of laterally rotated because of weakness of lower trapezius, which should control the going the should control the motion. Like if the scapula is going upward, so they have contraction of the upper trapezius, and lower trapezius should control the motion as well, so that it's not going too fast, it's going to over motion. But if the weakness of lower trapezius, so that's why they cannot control the motion of the scapula over here. Similarly, it's not just lower trapezius, it can be because of the weakness of latissimus dorsi, so that's why it cannot control the scapula in the right manner. All right. So before we proceed to the treatment, so of course, we need to do an assessment. So what assessment that can be done for the scapula is first observation. Of course, we need to observe, like what we are doing, we are observing. We observe the scapular motion during rest. First, during rest, so that we know the scapular position during rest. What kind of scapular position? Is it a normal position or is it in positional fault position or scapular dyskinesia? It can be a first assessment. Okay, that's the first observation at rest. Second, we have to check the observation during motion. How the scapula movement during shoulder abduction or flexion. So we can see the position of the scapula, how the scapula move along the thoracic rib. Next, we can do a test for which is scapular assessment test and also scapular retraction test. So these two tests is used to confirm if the patient is having scapular dyskinesia. Right? So here I'm using...
To perform the test, fixate the clavicle.
Okay, so I'm using the video from the Physiopedia for scapular assessment test, so you can check how...
To perform the test, fixate the clavicle and the scapular spine with one hand, and with the other hand, grab the inferior angle of the scapula. Then ask the patient to perform elevation or abduction and assist the movement of the scapula. The test is positive if the patient experiences less pain during the assisted movement in comparison with the non-assisted movement. A positive test indicates weakness of the scapular stabilizers because assistance stimulates the function of the serratus anterior as well as the lower
All right. So, what we have to do first is we have to do shoulder abduction without holding, without stabilizing the clavicle and inferior body of scapula. So we ask the patient to do it first. Okay, if the patient is in pain, or you can see there are a delay of the muscle, or you can see they are overactive in the muscle. Usually we can see that. Okay, because the position of scapula will move more faster compared to the good side. All right. So after we do that motion, we can stabilize. This is what we call scapular assistance test because we want to compare before and after. Okay. If we do it at the first begin, we can see the scapular motion is not in a good position and the patient is having pain. So the next motion, we try to stabilize the scapula and also the clavicle. So the pain is reduced. So that is a confirm for the patient is having scapular dyskinesia. Why? Because the second reason, the second test, which is SAT test, we already stabilize. We already stabilize the structure. So that's why the patient is having less pain. Compared to the first beginning, the patient, we do not stabilize at all. We do not put the scapula in the right manner. So that's why the scapula is in pain. So when we do the scapular assistance test, we already stabilize it. We already stabilize it in a good manner and we control the motion of the scapula. That's why the pain is reduced. So we want to check this test is can be done for this scapula patient or any upper extremity patients. Okay, that's the second test after observation. Lastly is scapular reflection test.
As we have learned in the SAT test, scapular dyskinesia can lead to shoulder impingement problems when the scapula is not sufficiently following the movement of the humeral head. To perform the SRT, fixate the clavicle and the spine of the scapula with your hand, and with the forearm of the same hand, press the scapula of your patient against the chest wall. With the fixation of the clavicle and the scapula, perform the empty can test. The SRT test is positive if the pain during the empty can test is reduced. Like in the SAT test, a positive test indicates weakness of the serratus anterior and the
Okay. Similarly, we have to do empty can test first without holding the scapula. So usually they will have positive in pain. So that we claim pain because there's no stabilization over there. But once we stabilize the structure, when we stabilize the clavicle and scapula, the pain has been subsided. So we get the idea already. So what we're going to do is we have to put back the scapula in the right manner and we have to give more strengthening exercise for the weakness of the muscle because the stabilization of the scapula is very important to make sure the movement of the shoulder joint. All right, so the question is how to apply motor control. Okay, first we have to reposition the scapula at rest. Okay, next, patient is taught to actively reproduce correct orientation using visual, auditory palpation, and the exercise is in a slow manner and hold for about 2 minutes. Okay, we do it for 2 minutes, repetition for 10 times. We can do this exercise 4 to 6 weeks. So this is to get the motor control first. After we get this one, then we can proceed to strengthening exercise for GH joint. Okay, we get the scapula first. So the question is, now we have to reposition the scapula. So reposition of the scapula, so just now we can see here, this is the patient. Okay, so we have to do the motor control at rest. So here we can see the inferior border is in anterior tilted position. So we have to ask the patient. So here, patient is taught to actively reproduce correct orientation using visual. By visual, by means we have to ask patient to move the inferior downward, going inward. So by means they have to open the shoulder and get the inferior border close to the rib cage. Ask the patient to open the shoulder and get the inferior border to that rib cage. Hold there for about 2 minutes. Okay, just open the structure. So that's how we get the scapular control. Okay, similarly. So this one is for they have the abduction of the scapula. So ask the patient to retract the scapula in the right manner. Okay, when we go retraction, hold there for about 2 minutes. But however, there are certain conditions patient cannot do by visual. They do not understand. So we have to reposition the scapula. We are going to hold the scapula in the right position. Then we ask the patient to contract. That is we can do as well. That's how we guide the patient using palpation. Okay, we get the scapula, we move, we stabilize just now like the test of SAT test or SRT test. We stabilize the scapula in the right manner. Okay, we put the scapula in a good position, then ask the patient to control, to retract, and also to contract that muscles. But at the same time, we have to check. Okay, usually that upper extremity here, upper trapezius and also levator scapula is overactive. So once the patient active, so sometimes they have activation, usually most of it, if the muscle is overactive. When we do retraction also, this upper trapezius is activate as well. So this is where we have to teach the patient to control the motion, not to contract the upper trapezius. Ask them to relax as much as they can while inferior. Put the inferior going to the rib cage. So by means we have to contract this muscle and relax this muscle. Okay, we have to relax the overactive muscle and work on the underactive muscle. Okay, there are two techniques I showed. I repeat again. First is by visual by visual cues and also by palpation. So auditory, we ask the patient to do that motion. Sorry, that is auditory. Ask the patient to do that motion. If the patient cannot do, we have to reposition. We put back the scapula in the right manner. Then we ask the patient to retract, or we put the scapula to the rib cage. That's a treatment. Other treatment that we can do is we just repeat the SRT test and also the SAT test. We can repeat for that one. We put the scapula, we put the shoulder in abduction position, but we have to reposition. We are going to control that motion. We put the scapula in the right manner, then ask the patient to move the scapula inward. Retract going down, and also we put the scapula in retraction position and inferior body right to the rib cage. So that's how we do. So second, if we get the scapula at rest, after we get the scapula is repositioned at rest, after several weeks, usually the scapula is already in the right position at rest, then we can proceed. The scapula motion, we can do the motor control in motion. So we ask, once the scapula was placed in the optimal position, patient is asked to control the orientation while lifting arm in 90 degrees of shoulder elevation in frontal, sagittal, and scapular plane. So once they have the scapula in the right manner, so we can ask the patient to move the shoulder. Okay, they ask them to retract. Like for example, this condition is they have abduction. So ask the patient to retract the scapula inward while moving the scapula from flexion to abduction. We move from here, from normal position to abduction. So at the same time, you have to control, retract the scapula. And again, if the patient cannot do, usually at the first beginning, they cannot do that motion. So we have to reposition the scapula like the SAT test or SRT test. So reposition the scapula, ask them to actively engage and move the scapula. But the difference with the test, just now for the test, they do not engage the motion, they do not engage the muscle. But for the exercise, for the motor control exercise, we have to reposition the scapula, ask them to engage the muscle, to contract the muscle, then they have to do the position. Like for example, in sagittal plane, we do flexion. Frontal plane, we do abduction. So in all position, you have to practice in all position. Okay. That is about the motor control. Again, I repeat, that is for rest. We have to do at rest first, then we can proceed to the movement. After that, okay, don't forget to check which muscle is overactive, which muscle is underactive. For the overactive muscle, make sure ask the patient to relax. Ask them repeatedly relax, because the overactive muscle, any motion, they're always overactive, always overactive. So we have to ask the patient to relax, and to relax. This is something that you have to always remind the patient, and to activate the lower part if the structure is overactivated like this. Okay, so the upper part usually overactivate, so you have to relax the upper trapezius and to contract more on levator, contract more on lower trapezius and also latissimus dorsi. Okay, with that motion. After we get a rest, then we proceed to the movement. Again, we have to ask the patient uh, to to relax the overactivated muscles. Okay, so when we're going to apply the manual technique. So the question is when we are going to apply the manual technique. If the patient cannot do this motor control position, so we can relax the muscle by applying manual technique to the tight muscle. We can do trigger point release, or we can do the manual just soft manipulation over the muscles. So that's how we can get the relaxation of the overactivated muscle. Okay, just for that muscle. We do not have to do for all muscle, no, just for the overactivated muscle if they cannot do in active manner. Okay, then we can go for manual technique. Right, we need to focus more on activated first, because if we just relax, because if we just do manual therapy without engaging the muscle, the treatment won't work. All right. So I hope that get the idea of motor control, how we're going to apply. So there are certain, now we proceed on the research study about the motor control as intervention. So this is from Worsley et al. This is in year 2020, if I'm not mistaken. So they have 16 adults with shoulder impingement syndrome. They use the questionnaire like SPADI score, okay, SPADI score, and also they use EMG to check for the muscles. So if you can see post-intervention, this SPADI score reduced significantly, and EMG showed delayed onset of early termination of serratus anterior and lower trapezius muscle activity pre-intervention, which improved significantly post-intervention. Okay, so usually for the scapula, the lower trapezius, like for example, if the scapula is in abduction, usually the lower trapezius is delayed. They have delayed onset, by means they have underactive muscle. It's very slow muscle that cannot engage well, so that's why they have delayed onset and early termination. But after they do the motor control for 10 weeks, they can see improvement in muscle of trapezius muscle and also serratus anterior. So it shows that this motor control is effective for impingement, for shoulder impingement syndrome, in reducing pain and also increase in function. Next study is from Milo. So Milo studying about the muscle activity for trapezius, which is upper trapezius and lower trapezius, serratus anterior, levator scapula in asymptomatic and symptomatic subject in chronic shoulder pain during functional tasks. So there are a few functional tasks that they do. Then they check for the muscle activity. Which muscle is overactive, which muscle is underactive. Okay, now after they check, after they do the assessment, they share, compared to asymptomatic subject with chronic shoulder pain presented with scapular upward rotation and winging adaptation. Okay, those who are in pain, they have active in lower trapezius, medial trapezius, and levator scapula. So this increase in motion, so that's why the patient is having pain and also upward rotation, and they have decreased activity is serratus anterior. So that's why the patient are in that position. The patient the scapula in winging. So in winging position, they're already not in a good direction. That means like if they are in abduction position, they have activated of the levator scapula, activated of trapezius, medial trapezius, and deactivated, underactive of SA. So in any functional task, these muscles are similarly. So by means like in any position, in any exercise, in any functional task, that the underactive muscle remain underactive and the overactive muscle remain overactive. So that's why in anything you do for chronic shoulder pain, they are in pain. So that's why we need to relax the upper trapezius, relax the trapezius muscle. We have to relax the trapezius muscle and to exercise for we do the control for we do motor control for serratus anterior muscles. So this is can increase the scapular muscle ratios. Okay, I think that is all from me. So this is a few references that you can check more in details about the motor control and also the scapular problems that related to shoulder impingement. I think, thank you.
Thank you, Ms. Aina, for the insightful presentation. Dear viewers, if you have any questions for Ms. Aina, please leave a comment. Okay. Now we have a question from Mr. Nelson Chia. What happens when there is a scapular winging?
All right. Thank you, Mr. Matthew, in the question. Okay, what happened? There's scapular winging. We need to understand why scapular winging happen. Usually they have many types of scapular winging. So inferior winging, lateral winging. So we have to check. In scapular winging is also known as scapular dyskinesia. Okay, in other words, they are the same term. They are the same problem. By means the muscle is imbalanced. They have muscle overactive, they are muscle in underactive. Like scapular winging, for example, this is my hand, this is scapular winging in this way. Okay, if the scapula is winging in this way, like for example, this is the spine, this is the scapula from the back side. So the scapula is tilted medially. So the tilted medially, so we have to check which muscle is underactive. So usually the winging, if the winging backward posteriorly, so this rhomboid muscle will weaken. It will weaken and inferior angle is weakened. The muscle that holding the levator scapula, the muscle that holding the inferior angle is weakened. So that's why the scapular winging is happen. So that's why in scapula motor control, ask the patient to bring the scapula inward to prevent the scapular winging happen. And also we have to, like I mentioned just now, we have to check which overactive muscle. Usually the overactive muscle is at the levator scapula and also the upper trapezius. We have to relax these both muscles and activate this down muscle so that the scapula in the right manner. So from this swinging position, we have to retract because this muscle is weakened. We have to retract and get back into the right position. Okay, or you can do in motor control, as I mentioned just now. We have to reposition. We have to reposition the structure and ask the patient to tighten the muscle down here. So how to get the scapula in the right manner if the patient is having scapular winging.
Okay, thank you, Ms. Aina. Okay, so now we have a question from Ms. Rose. Is the patient with acute pain than any other suggestion of physiotherapy exercises? In the patient with acute pain, then is there any suggestion for physiotherapy exercises?
Okay. Thank you for the question. We have to check back why the patient is having acute pain. Usually, acute pain is related to inflammatory process. It is the new injury, right? Acute usually less than 3 months, so it's new injury. So the best exercise we can give to the patient is isometric exercise. Okay, because we do not want to move the muscles yet, but we want to strengthen the muscle so that the pain is subsided. Okay, then you can, if the patient is too much pain, you can use the modalities. But modalities is the second option. Okay, the first option is what we can do during acute pain is we get back the strength. Which is we give isometric to the structure. because we want to relax that muscle. We don't want to stretching muscle is to lengthen, because if the patient the muscle is lengthened or moving, so of course they are in pain. So we want to strengthen the structure first, then we can go slowly with isometric before isotonic treatment.
Okay, thank you, Ms.
Thank you.
Aina. Okay, so I think we come to the end of the webinar. Uh, yes, we have to come to the end of this session. Thank you, Ms. Aina, for joining us today and providing such insightful information. To our wonderful audience, thank you for joining us at this webinar. We look forward to your comments and participation in future events hosted by MAHSA University. Have a pleasant weekend. Thank you. Thank you.